I'm actually personally really excited about the next two speakers. Our next speaker is Keese, a gentleman named Keese. Jay is, boy, has he made some major contributions to the direct primary care movement over the last several years. Jay heads up the Direct Primary Care Coalition, which is a Washington-based organization that has worked at the federal and state level to clear the path to allow this model to operate cleanly and free of some of the impediments that have gotten in its way. There's some exciting news, I think, on the horizon. There was some productive discussions that happened in Washington this week. I think Jay's going to give us an update on that as well. But Jay's here to kind of teach us about, from Washington and at the state level and from the legislative level, how DPC is viewed, the challenges that need to overcome, and the work that he's doing to make that happen. Jay Keese.
Thanks, Mike. We're going to talk about breaking the status quo in Washington. Wow. Well, how about them Washington Capitals? That's breaking the status quo. So it's been since 1992 since we've had a major champion of any sport out there other than politics. But we're going to talk a little bit about politics. We're going to talk about policy. And I want to thank Hint, really from the bottom of my heart. There's nobody that works in the DPC community that gets the DPC culture the way Hint does. And it's really representative of what's happening here today and the fact that you are all here in this room. And they've been a major sponsor of almost every fly-in that we've had. We recently had a group of folks, a lot of folks in this room came to D.C. We held 72 meetings in the space of about a day and a half. We heard from CMS and a number of other folks from the administration on exactly where things are going, and we're going to review some of those things. We're going to talk a little bit about the progress that we've been making on HR 365 and S 1358, the Primary Care Enhancement Act, and we're going to take a trip around the states to see what's going on the state legislative front. So we'll dip into a little policy, we'll dip into a little politics, and I think we'll have it all solved by the time we're done, and then Ryan gets to go. So this is the State of the Union in 2018. The coalition was founded in 2009 as we were pushing forward the legislation that wound up in the Affordable Care Act, Section 1301A3 of the Affordable Care Act, which allows, which was described direct primary care medical homes, and allows them to participate alongside qualified health plans in the exchanges and to count towards essential health benefit. And, you know, I think it certainly was one of those landmarks that woke people up. Here is, you know, a major market-based reform put forth in the Affordable Care Act. And we founded the coalition because, frankly, we were getting asked, you know, we're talking a lot about what's going on in Seattle with Q Lions. Is there anybody else that's doing this? Are there other places in other states? And we did find about 21 practices around the country in 2009. Now, we know there were more. There were a lot of people doing direct primary care. It hadn't been called direct primary care. But we went from 21 in 2009, and here we are almost 10 years later. This is really a sort of virtual network of 800 practices or more. I think that's also a low number. You all recognize the mapper from Phil Eskew's Direct Primary Care Frontier. This is the best data we have on where direct primary care is today. We suspect there are more, but that's pretty tremendous growth. So over 800 practices, obviously a mix of large and small practices. You know, median fees about $80 per month, better outcomes. The data has been pretty consistent. You've seen a lot of that today. What's interesting about the data is that, you know, it isn't a lot of data. There aren't, you know, millions of patient lives over 20 years in this. But we now have about 10 years worth of very consistent data that points to up to 20% and more, 22, 24% reductions in the total cost of care, based on claims data from employers who are doing these DPC arrangements for their employees. I'm hitting the wrong button. So I love this map because this is the map about where all the state laws are. And it used to be a little bit like, a little patchwork, but now you can drive your car all the way from one end of the country to the other and go through states that have laws that have defined direct primary care as a medical service outside of state insurance regulation. And we think that's pretty exciting. I mean, if you look at all of this growth, we've passed 10 new laws just in the last year. We also have 3 states, Massachusetts was the first, followed by Montana and Illinois, that have had really good, solid regulatory guidances. So in more than half the states, we have now worked really hard with local docs on the ground and with state legislators and with others to try to get direct primary care defined correctly as the medical service that it is, and as a genuine health reform that's driving the needle on cost and quality. We need to keep doing this. I mean, I don't think there's really any state left where it's absolutely prohibitive. There are workarounds, but we're going to continue to keep pressing on the state front, and we know there's at least these states here in blue, and we heard recently that Arizona is revisiting theirs. So Pennsylvania, South Carolina, Minnesota, we're working there on legislation that some of those states could even pass this year because they're more full-time legislatures. So we've talked a lot about this today, but I think this is really important because why are we doing all of this? I mean, we're doing all of this because we want to scale DPC and we want it to grow. And the people that are doing that, I think the hardest and that are most interested in doing that right now are employers. You look at some of these arrangements that are happening around the country. We've worked directly with a number of these folks. There's a coalition of about 60 different employer groups around the country that supports our legislation in Congress. We've been working closely with organizations like the U.S. Chamber of Commerce and the National Retail Federation and the American Benefits Council and a lot of their members. We've been working really closely with Boeing that's partnering with IORA to offer a direct primary care benefit for Boeing employees in Arizona. They want to scale that to their employees all over the country. And, we're really thankful to the resources that they've been able to bring to the table to help move direct primary care. Why are they doing that? Because they're nice? They're doing it because it works. It helps their employees get healthier. It keeps people out of the hospital, and it saves money. State employees groups all over the country. The first one was in New Jersey. We've got Our Health and Paladina both working with the state of New Jersey Employee Health Benefits Plan in a program that was put together by 9 state employees unions that got together to bring direct primary care as an option to their members. So now you can go in and you can pick the HMO, or you can pick the PPO, or you can pick the direct primary care relationship, no co-pays, no deductibles, first dollar coverage for primary care. That really appeals to people. And I would say to the person in the audience who asked, how can we support more people being interested in primary care? I just want to say it from the patient's perspective. People want this. We want this. I was finally waiting to get into a direct primary care relationship, and we did it for our family this year. We're working with Matt Hayden with Mobile Modern Medicine. And we've signed up with Matt, who works with Clint Flanagan over here at Nextera and as an affiliate partner. And he's got great coverage. We're using the Spruce app to communicate with Matt on all of our prescriptions and all of our out-of-office medical needs. And it's just great. And these employer groups are doing this not only because their employees love it, but because it really moves the needle and it really does make a difference. We've seen health systems get involved. I think it's really important to keep everything in perspective. And Zach mentioned this before. It's really true. We've worked really, really hard to make sure that whatever it is that's special about DPC is maintained as we move into these relationships. If you've seen one DPC practice, you've seen one DPC practice. There are lots of different ways to skin the cat. And at the Coalition, we really feel strongly that we want these 1,000 flowers to bloom, and that the answer, DPC isn't going to be the answer for everybody. It will be an answer, and there's going to be lots and lots of different versions of what direct primary care is. But at its core, it's a direct relationship with a personal physician that builds the relationship, that centers the care around that relationship. Frankly, while perhaps one of the best models that's working out there right now is where the individual pays the doctor directly, there's lots of relationships where the employer is paying and where there are risk-bearing models. We need to explore those, take a look at them, and see which of these models really flesh out as the best model. And there's lots of different ways to do it. These employers are exploring all of these ways. So I would encourage you, if you're not doing it, work with your employers. And talk with your employers as these laws are passing forward. They're some of your best advocates. I mean, frankly, we've done a great job working on some of this legislation, but when Boeing and the Chamber and these other organizations step up and help us with our legislation, it moves through. I mean, we were in Nebraska. We got the Blues support for the legislation that we passed in Nebraska. So we'll talk in a little bit about where some of the plans have been on our federal legislation that we've been working on too. Again, with regard to scale, I think everybody in the room is probably aware that in April, the Center for Medicare and Medicaid Services put out a request for information about a new direction that we feel is incredibly exciting for CMMI. Now, a word about CMMI. The Center for Innovation was established in the Affordable Care Act with an amazing amount of power, frankly, to test and innovate new models for Medicare. The Section 3021 legislation that created and authorized CMMI was funded with a $10 billion fund. And the idea is that CMS has to test these different payment and delivery models, advanced payment models. And if CMS tests these models and shows that they improve care and they don't cost anything more than we're already spending now, CMS actually has the ability to make these demonstrations permanent. So about a year and a half ago, the president put in his budget proposal a line item that asked for a direct primary care pilot for CMMI. So CMMI issued an RFI in November broadly about what some of these things might look like, and they came out with a more narrow request for information on what they called direct provider contracting. Now, one of the first things we said to CMS is, you've co-opted a couple of initials that mean an awful lot to people, a lot to people in this room, but not only that, you co-opted some initials that mean something now in 25 different state laws in the Affordable Care Act. So we've had a good dialogue with them. We worked closely with them as the RFI was coming to light on a whole lot of research and data gathering. I think some people in the room took part in some focus groups with CMS and took part in a survey that CMS did. They put forth a request for information. This is an opportunity to tell CMS, hey, if we're going to do things, what should they look like? And what our response to the CMMI request for information is on the website, dpcare.org. You can download it and take a look at it. But we told CMS that they ought to really try a couple of different models. Because as we said, there's a lot of different ways to do DPC. First among those models, they ought to try it the way it's being used most commonly in the marketplaces that exist today. I mean, part of what CMS is trying to do is to test market-driven ideas. So go to the marketplace. Look at how it's being done. There's people in this room that see Medicare patients. Almost all of you have opted out of Medicare. So let's take a look at getting some of those Medicare patients and use a very little known provision in Medicare law. That provision is called a Medicare savings account, an MSA, that exists in Medicare, not very well utilized. So we said to Medicare, why don't you take the existing DPC practices who have Medicare patients, put a contribution into that Medicare, into a Medicare savings account, and allow that account to be used towards the purchase of a direct primary care relationship. We also suggested that they take a look at a couple of other models. They're obviously going to want to take a look at a model that would test a direct contribution to the practice. There are some larger practices around the country that are going to be interested in doing that sort of model. We think that the direct provider, direct payment to the beneficiary might appeal to some of the smaller practices. There might be another model that looks a little bit like a capitated ACO, where you take a direct fee and then you do some cost sharing around it. So we're very bullish on this. We do expect that CMS is going to announce a demonstration that will test a direct primary care model. And we want to encourage them to move in that direction because it's an important part of scaling it. Now, one of the biggest problems that remains, we've talked an awful lot about this over the years, is HR 365, is the fact that you can't use your HSA with direct primary care. And you can't not just use your HSA with direct primary care. You run into a prohibitive situation where you're not even allowed to have a relationship with your direct primary care provider and fund your HSA. The legislation is moving. We had a hearing this week in the Ways and Means Committee. Thanks to Garrison, he mentioned that a little bit before. This was the first bipartisan bill introduced in the United States Congress, in the 115th Congress that we're in now. We're moving the ball down the field. We had a hearing. So everybody remember, I'm a bill sitting here on Capitol Hill. So that's the first box you've got to check to move a bill. Well, we've checked that first box. We've had a good legislative hearing. We had a great bipartisan dialogue. We'll have that up on the website shortly, but you can check that hearing out from Wednesday of last week at the Ways and Means Committee. About an hour into the hearing, our sponsor, Mr. Paulson, and Representative Blumenauer from Oregon both praised DPC and turned this, what might have otherwise been a fairly partisan hearing, into a really bipartisan cry to get the problem with DPC and HSAs fixed. So we feel good about that getting done. There's opportunities to do it on legislation moving forward. This fall, we think there will be a markup of this bill sometime before August recess. So what I'm going to leave you with is this. A lot of people have asked me, what's the date? When are we going to get this? When are we going to get it done? Obviously, we cannot promise when Congress is going to pass a particular law, and we are also going into an election year. But what we can say with great certainty is the more co-sponsors that we have on this bill, the better the chances are that this is going to move. Now, we have a lot of good bipartisan interest. We have members of the leadership. We have members of these key committees like Ways and Means and Finance who have sponsored this bill. We have Democrats. We have Republicans. We have Maria Cantwell. We have Rand Paul. That's the entire political spectrum. So let's try to move it. So what I would ask, in red at the bottom of this slide, go to our website, dpcare.org. At the top of the website, there's a link to where you can contact your member of Congress, send them an email, ask them to co-sponsor HR 365 if they're in the House, or S 1358 if they are already co-sponsors, and that information is up on our website as well. Thank them, but try to get more co-sponsors on this bill. This is the way we move it. We'll be announcing plans for an upcoming fly-in, likely in September, shortly. So we want you all to come to Washington. We want you to be a part of that movement. Help us move the bill. Help us help you. And with that, I'm out of time.